Yeah, good afternoon, everyone. So, welcome to yet another edition of continuing education webinar series conducted by Vijaya Diagnostic Center. So, I thank you for joining us today. I am Dr. Jnankumar Chaudhuri and head of the Department of Biochemistry at Vijaya Diagnostic Center. Today, we are presenting biochemical cardiac markers to be presented by Dr. A. Prathibha Rani. So biochemical cardiac markers are substances which are released into the bloodstream when the heart muscle, that is myocardium, is injured. They play a crucial role in the diagnosis, risk stratification, and management of cardiovascular diseases, especially acute coronary syndrome or ACS, such as myocardial infarction. So these cardiac markers or biochemical cardiac markers, they help in early detection, specificity, and sensitivity, and also guiding the treatment. So our presenter today, Dr. A. Prathibha Rani, is a consultant in biochemistry at Vijaya Diagnostic Center, and she completed her MD in biochemistry, I think 5 years back, and she has that much experience in the subject. So if you have any questions during the presentation, please type them into the question box in your control panel, and I'll bring them up at the presentation after the end of the presentation, and we will have the time for questions at the end. So now, without further ado, we'll turn the time over to Dr. Prathibha Rani. Dr. Prathibha Rani, please.
Good afternoon, everyone. Good afternoon, sir. And today's my topic of presentation is biochemical cardiac markers. So these are the intracellular macromolecules released from the heart muscle whenever there is damage to the damage due to the myocardial infarction. They are found in the blood. They are usually present but elevated during the damage to the heart muscles. The different cardiac markers are AST, troponin INT, creatinine kinase, myoglobin, LDH, BNP, HSCRP, myeloperoxidase, and ischemic modified albumin. And this is one of the pictures showing the pathophysiology of the myocardial infarction, where the atherosclerosis causes obstruction, which leads to the hypoxia and which eventually leads to the necrosis and the myocardial infarction. And this is also one of the diagram where it shows how the plaque is formed in the artery and which causes the obstruction and leads to the atherosclerosis. And the criteria for the ideal cardiac marker is that it should have good specificity. Means it detects only the cardiac damage and optimal sensitivity. It is detectable when the damage is preventable. And it is also related to the amount of the injury and also enables in prognosis and prediction. But there is one thing that no single marker meets all the needs. So next is the creatinine kinase. It usually catalyzes the formation of the phosphocreatine from the creatine and the ATP. There are both cytosolic and mitochondrial isoenzymes. The cytosolic forms of the enzyme is a dimer. So it consists of two subunits, M and B, and it also has three isoenzymes. So that particular CKMB isoenzyme is specific for the heart. The normal value of the total CK in men is 24 to 190 international units and in women is 24 to 170. And the CKMB usually in the blood, it will be less than 25 international units per liter. So this is once again the image showing how the phosphocreatine is formed from the creatine by utilizing ATP in presence of the creatine kinase. So this enzyme gets elevated whenever there is a myocardial infarction, and the surge also depends upon the extent of the heart tissue damage. And it shows significant rise in the bloodstream following an MI. But it also returns to the baseline first, I mean, like immediately. Levels can also rise in certain cases of coronary insufficiency, though even though when MI is not there. So it is not it's not more precise. I mean, like CKMB begins to elevate within 4 hours, and in case of acute myocardial infarction, and peaking around 24 hours, and the peak level can vary between 10 units to 40 units, depending upon the infarct severity. And compared to total CK, CKMB is more precise and sensitive marker for acute myocardial infarction. And the next cardiac marker is the lactate dehydrogenase. And it also facilitates the reversible conversion between lactate and pyruvate through oxidation. Uh, the normal reference ranges of different LDH isoenzymes are as follows. Total LDH is 125 to 290 units per liter, and LDH1 constitutes about 20 to 30% of total LDH, and LDH2 makes up to 30 to 40, and the level is 115 units per liter, and LDH3 accounts for about 17 to 23%, and its level is about 65 units, and LDH4 is about 3 to 13%, and its value is 40 units per liter. And LDH5 is 4 to 12% of the total LDH, and it constitutes roughly about 35 units per liter. So total LDH rises within 12 to 8 hours and peaks for 48 to 72 hours, becomes normal by 6 to 10 days. Whereas LDH1 rises within 10 to 12 hours and peaks by 72 to 144 hours and becomes normal by 10 days. And there is something called LDH1 to LDH ratio, and this gets flipped during the myocardial infarctions. And this, along with the high rise in the CKMB level, confirms the myocardial infarction. And this is the another cardiac marker, serum aspartate transaminase. So AST is almost found in all body tissues, and it is high in heart and liver and moderate in muscles and kidneys. So the normal value is 6 to 25 units per liter, and it starts to rise about 6 to 12 hours after a myocardial infarction, and peaking around 24 and 48 hours, and returns to the normal levels within 4 to 6 days. Compared to creatine kinase, AST surge is milder and occurs later in the timeline. So it is less precise in diagnosing the myocardial infarction. And there is another cardiac marker, myoglobin. This is an oxygen binding protein in the heart and the skeletal muscle. And this myoglobin rises after the muscle injury and also during the crush injuries, and also in myocardial infarction. It is an early blood marker for the heart muscle damage, and because it is released quickly from the injured cells. And myoglobin rises within 1 hour. Excuse me. Within 1 hour after AMI, peaking at 4 to 12 hours, and this peak shows early heart muscle damage, and it clears quickly. Excuse me. It clears quickly, reducing sensitivity after 12 hours. And myoglobin helps to detect AMI in first 4 hours than before CK. And it's not widely used because it is non-specific and rises with any muscle injury. Even minor muscle damage can rise the myoglobin, and it can lead to the misdiagnosis of the acute myocardial infarction. Troponins are the next cardiac markers. Troponin consists of 3 distinct protein components, C, I, and T. And these proteins exist in various forms depending upon the muscle type, and is differing between cardiac muscle and both slow and fast twitch skeletal muscle. The cardiac version of troponin C is identical to the form found in the slow twitch skeletal muscle. It means it cannot serve as a specific marker for the heart muscle damage. Troponin T and I are unique to the heart and serve most precise and reliable indicators of acute myocardial infarction. So after a myocardial infarction, troponin level begins to rise simultaneously with the enzymes CK and CKMB. Remain elevated longer due to the gradual release from the injured heart muscle tissue. Following the onset of the symptoms in acute myocardial infarction, the serum levels of cardiac troponin T and I rise within 4 to 8 hours, mirroring the initial increase seen with the CKMB. Unlike CKMB, troponin T and I remain elevated for an extended period, lasting between 5 to 10 days. The prolonged elevation allows cardiac troponins to effectively replace the LDH assays for identifying patients who present late for an AMI. In individuals without cardiac conditions, the serum levels of cardiac troponins are extremely low and undetectable, enabling troponin T and I to provide superior risk stratification compared to the CKMB. Cardiac specific nature of troponin T and I helps prevent false positive acute myocardial infarction diagnosis. And troponin T serves as a reliable marker for myocardial damage in various clinical scenarios like sepsis, drug-induced toxicity, chronic illnesses, cancers, hematological disorders. And this is another picture showing how the cardiac enzymes get elevated during the myocardial infarction and how long, till how many days they will be elevated and they come back to the normal levels. HSCRP. The high sensitive CRP assay detects very low concentration of the CRP, C-reactive protein, which helps to uncover the subtle inflammation and which is related to the risk of cardiovascular disease. It may be performed in individuals at intermediate risk of developing CHD who are metabolically stable without inflammatory and infectious conditions. The clinical significance is it is a well-documented marker for general and cardiac-related inflammation. And in healthy individuals with elevated CRP levels, they are up to 4 times more likely to have coronary heart disease in future. So elevated HSCRP is associated with the risk of the future cardiovascular events, even in apparently healthy individuals. So reduction in both HSCRP and LDL cholesterol are associated with the reduction in the rate of atherosclerosis and also improved clinical outcomes. So the statin therapy can help with the elevated HSCRP, and even with the normal lipid levels, significantly it reduces the risk of the myocardial infarction, stroke, and death. So this is how the levels indicate the risk, which is associated with the elevated HSCRP levels. And how frequently you should test the HSCRP. The frequency of testing is determined by the individual's medical history, but an elevated HSCRP should be confirmed with an additional measurement with, at least 1 month later. So for the levels greater than 10 mg per liter, the test should be repeated 2 to 3 weeks, as levels above 10 can reflect acute infection. And the homocysteine is another cardiac marker, which is an amino acid produced as an intermediate during the metabolic conversion of methionine into cysteine. So the factors contributing to the elevated homocysteine levels are hyperhomocysteemia, and also there are certain genetic mutations which affect the affecting the enzyme cystathionine beta synthase, and also the deficiencies in vitamins like B6, vitamin B12, and folic acid can also lead to the elevated homocysteine levels. So the normal plasma homocysteine levels are below 15 micromole per liter, and elevated homocysteine significantly raises the risk of the coronary artery disease and arteriosclerosis. And it harms the vascular endothelial lining, and even slight increase in homocysteine can impair the function of the vascular endothelium. Natriuretic peptides are the another class of cardiac markers, and A and P. In this, there are 3 different types: atrial natriuretic peptide, and brain natriuretic peptide, and C-type natriuretic peptide. Alpha atrial natriuretic peptide composed of 28 amino acids, in which the N-terminal pro-ANP contains 98 amino acids. Whereas in case of BNP, it is made up of 32 amino acids and N-terminal contains 76. Whereas in C-type natriuretic peptide, it is with 22 and 53 amino acids respectively. So ANP is released in response to the atrial wall stretching and intravascular volume expansion. And BNP is mainly secreted by the ventricles. And C-type natriuretic peptide is predominantly found in the brain and is also synthesized by the vascular endothelial cells. So this is one of the pictures showing how when a patient presents, I mean, like in clinical examination, after the clinical examination, they'll do the ECG, chest X-ray. And when they test natriuretic peptides, if NT-proBNP is less than 400, it is unlikely to be a chronic heart failure. And if it is between 400 to 2000 picogram per ml, it is an uncertain diagnosis. They have to evaluate further. And if it is greater than 2000, it is more likely to be a heart failure. So they even in that case, the consultant goes accordingly. Thank you.
Thank you, Dr. Prathibha Rani. So we have for this very informative presentation on this important subject. So we'll now go ahead and take some time for the questions now. Just a reminder to all those who are listening, please be sure to type your questions into the question box in your control panel. So it looks like we have few questions. So what is the most specific marker for MI? That is one question has come from one of the audience.
So high sensitive troponin I is the most specific cardiac marker for the most specific cardiac marker, sir, because it rises immediately and it stays for the prolonged time. So it is a specific marker, more specific marker.
Yeah. One more audience has asked for us to elaborate regarding the LDH flip.
Yeah, LDH flip is like usually the LDH2 isoenzyme is more elevated normally than the LDH1. But in case of myocardial infarction, what happens is that the LDH1 rises more than the LDH2. So it is a clear indication that there is some heart muscle damage. And this along with the CKMB rise indicates clear diagnosis of the myocardial infarction.
Okay. So another question has come. What is the gold standard marker for gold standard cardiac marker for MI mainly myocardial infarction?
It is a high HS troponin I, sir.
And one audience has asked regarding BNP or NT-proBNP, which to be preferred for cardiac failure, like as a marker for cardiac failure.
So
Just
BNP,
assay of BNP or NT-proBNP, which is to be preferred.
BNP has a shorter half-life and it is unstable actually, but pro-BNP is stable and is having higher concentration, and it stays in the blood for longer time. Half-life is more than the BNP for NT-proBNP. So it is more better cardiac marker than the BNP.
Okay. So it looks like we have covered all our questions. So Dr. Prathibha Rani, is there anything else you wanted to cover before we wrap up?
Nothing.
So
Nothing, sir.
great. Thank you, everyone. So we appreciate you all being here. A recorded version of the webinar will also be available. So thanks again for joining us today, and we'll see you next time. Thank you.
Thank you, sir.